Our patient, Mrs. X, 75 years old, presented to us with the complaints of anorexia and sensation of fullness after meal for last 4 months. Vomiting occurring almost daily, usually 15 to 30 minutes after taking food for the last 2 months. It was projectile, non-bilious, colorless, sour in taste, containing partially digested and undigested food material that she took previously. She usually felt some relief after vomiting. She also complains of occasional rolling of mass from left to right. Patient has a history of 8 kg weight loss in last 4 months. Her bowel and bladder habits are normal. She has a history of 1 unit of blood transfusion. She has no history of cough, hemostasis, hematomesis, melanine, and jaundice. She is a non-smoker, non-alcoholic, and has no comorbidity. There is no significant family history. She occasionally took PPI, and there is no significant drug history. On examination of the patient's vitals are normal. She is anemic but non-icteric, and her BMI was 18.3. ECOG performance status was 1. No accessible lymph node, including the left supraclavicular lymph node, were palpable. Abdomen was normal in shape. Visible peristalsis was present, and from left to right on palpation. There's no definite lump present, but there was a doughy feeling in the left hypochondriac epigastrium umbilical region of the abdomen. No organomegaly was present. No ascites. Succussion spurs was present, and other systemic examination and DRE reveals no abnormality. So my clinical diagnosis is gastric outlet obstruction, may be due to carcinoma stomach.
Investigation would like to advise to your patient, Dr. Rakib?
So I want to do some basic investigation for complete blood count and serum creatinine, serum electrolyte, ECG, and then I want to do the upper GI endoscopy with biopsy.
This is the reports of your endoscopy of the upper GIT of this patient.
Yes, sir.
So, adrenal carcinoma with pyloric obstruction.
Yes, sir. And
Are you happy with this endoscopy report, or you want to have more information from the endoscopy report?
Yeah, since it is, you told gastric outlet obstruction, so you have to give Riles tube gastric was before going for endoscopy. And then they mentioned the biopsy taken. So how do you take biopsy? What are the any protocol is there? And
sir, we have to take
one place or yeah.
So 4-quadrant biopsy, 6 to 8 biopsy should be taken, and it should be from the periphery, not from the center.
It is your view, but what about no information is given here? That's correct?
Yes, sir.
Okay.
Yes, sir. How many biopsy was taken is not given here. Yes, sir.
Any other thing, Dr. Patashwarthi? Do you want to make
Yeah,
a comment?
usually if it is the ulcer, no gastric ulcer, pre-pyloric ulcer, then we have to take all quarter, no, around 4 to 6 biopsies from the edge of the ulcer, and then 1 or 2 biopsy from the base of the ulcer we have to take. Suppose if it is the distensibility is not there, and it's not sometimes it won't produce obstruction. It's a lineatis plastica, then diffuse infiltration, lineatis plastica. Then we have to take biopsy from the same site multiple times, and that is called well biopsy. Because now it will be we have to go to the muscularis mucosa, we have to take biopsy. So that's why in stomach, if the distensibility is not there, then we can go for a well biopsy. And this type of cases, minimum 6 bit of tissue is required from the edge of the ulcer and then center of the growth. Yeah.
The report shows adenocarcinoma intestinal type.
So how do you proceed? What is your next?
Yes, I want to do contrast enhanced CT scan of chest, abdomen, and pelvis.
Chest, abdomen, and pelvis. Such like the CT scan of the chest with contrast, the thick right oblique feature, and please clinically, but no other abnormal findings in the chest. Okay. And this is your abdominal findings. You can see the length of the lesion is about the 4 centimeter. and hugely dilated with a gastric outlet obstruction, perigastric changes, no pedestalopathy, no pedalopathy, and the pancreatic involvement, no staging, T2H0, M0.
M0.
So this was about your CT scan of the abdomen report. Are you happy with this report? Any comment?
Yeah, it is no very huge stomach. It's going up to the pelvis.
Yes.
So the patient has no preoperative preparation is very important, particularly for this patient. So particularly Rayleigh tube, thick or large bore Rayleigh tube, nasogastric tube with a wash daily, at least for 3 to 4 days before surgery is recommended.
Right.
CT wise fine. It doesn't look like any node. And so what is the next line of how do you proceed for this patient?
So after proper optimization and preparation of the stomach, I want to go for staging laparoscopy with peritoneal level cytology, and then proceed accordingly.
Good. Okay. Anything you want to
Are you
add?
submitting patient for neoadjuvant stomach this patient or routinely?
Sir,
Are you doing?
Sir, if the patient has features of gastric outlet obstruction, so I want to first go for the surgery and to relieve it. There is
Yes.
Okay.
So what type of surgery you are planning?
so if there is no peritoneal metastasis and peritoneal level cytology was negative,
It's also
and
negative,
then I want to go for the subtotal gastrectomy with D2 lymphadenectomy with Rho NY gastrogenestomy.
So it is a distal subtotal gastrectomy with Rho and Y anastomosis. Okay. You have to tell D2 lymphadenectomy, particularly for stomach.
Yes.
No?
Yes, sir.
Right.
Stomach is the only organ in human body. They have a stage 3B, lymph node, stage 3. All everywhere will be stage 2, 3, 3B is there. So the lymph node clearance is the key for the gastrectomy. So always you have to maintain the distal subtotal with the D2 lymph node.
D2 lymphadenectomy. Yes, sir.
Okay then. So patient had surgery, and ultimately the histopathology report is like this.
Yes, sir. The histopathology shows proximal resection margin and distal resection margin were, histopathological type was adenocarcinoma, grade 2, moderately differentiated, lymphovascular invasion, perineural invasion was absent, and necrosis was absent, momentum free, extent of local invasion, tumor invades the musculus propria, and resection margin were free, both proximally and distally. In lymph nodes, laser curvature 16 in number, none of them shows any metastasis. Greater curvature 8 in number, none of them shows any metastasis. In level 2 lymph node, 9 in number, caseating granuloma with follicular hyperplasia. So the pathological staging was PT2, M0, and MX, but we have done the CT and chest abdomen, so it is M0, should be M0. And diagnosis, stomach partial gastrectomy, examination shows tubular adenocarcinoma grade 2.
Dr. Pansat, will you make any comment on this histopathology report?
So it is almost more than 35 nodes taken, and all nodes are negative. And I think very lucky patient. It is total obstructive lesion, but all nodes negative, perineural invasion is not there. And lymph node clearance also, it is very much adequate. This case. Yeah.
Okay, thank you. Dr. Kamal, can you hear me? Dr. Kamal? So this patient now for only observation?
Sir,
what type of, you have done a Rho and Y anastomosis or loop GJ?
The Rho and Y gastrogenestomy was done.
Okay.
I think it is, now what is really needed for this patient
Yes,
is what.
Azad bhai.
Yes, yes. This patient had a customer stomach distal tumor with a gastric outlet obstructions. So decision has been taken to do a surgery, and patient has a distal gastrectomy along with the Roux-en-Y anastomosis and D2 gastrectomy, and this is the histopathological report. The all margins are clear, no perineural invasions, and the total lymphatic clearance up to the level of the D2 is about the 35, and no one is involved by the tumor. And the pathological staging is PT2, PN0, and PMX. So,
So normally in stomach cancer, Ajay bhai, if it is PT1 in 0, we can safely keep the patient on observation. But in T2, we can either go for adjuvant chemotherapy and also we can go for observation. But even it is a wonderful surgery. I mean, I'm amazed to see the level of dissection. But still, I think we are not doing the surgery like the Japanese because they do something different. So if you ask me in the tumor board, I will be pushing for adjuvant treatment because first chance is the best chance because it's a very good surgery done. There is a very good chance of cure. So why to miss the opportunity by not to giving some adjuvant chemotherapy? Because end of the day, we know still there is a chance. So even there is observation opportunity, but I will be recommending chemotherapy. But if somebody put the observation, there is no harm in it. But in tumor board as a member, I will be pushing for adjuvant chemotherapy.
thank you. What is your opinion, Dr. Partha?
Yeah, what we follow here is T2 means we usually we observe the patient, and particularly the distal tumor, and even literature says the bursectomy is not much advantageous. What we feel is the post-wall of antral post-wall tumor and then pylori tumor, and we are going for a bursectomy. Young age means total bursectomy. This type of 70 years old lady, then we can go for a partial bursectomy. And we feel that it will be better survival, and our preference is observation. Yeah.
Okay, okay then. Thank you.
So, I mean, as I said, Ajay bhai, I mean, we can always discuss. There is an option because
Yes.
again, what I missed very important is the patient's choice. We need to discuss with the patient also that there is a small. We can give it if they say that they want to opt for the observation. We can always keep the because I said it's a clean cut in T2. We can keep both the option, but T1 only observation.